the presentation. Oh, I forget, I always read the slides. And so, yeah, so we will get started with Holly and Beatrice. So thank you all.
Great, thank you so much. Good afternoon, everyone. Thank you so much for having us. As Zakiya mentioned, my name is Beatrice Zovich, and I'm from the Hepatitis B Foundation, and I'm joined today by my colleague, Holly Moore, who also worked a great deal on this study and will be helping me to deliver this presentation. So the focus of today's webinar will be hepatitis B and Delta in the harm reduction space, and we will speak to the findings of a recent study that we conducted in partnership with the Harm Reduction Organization in Philadelphia. So this project was conducted in 2 phases. The first was an assessment of kind of existing levels of knowledge and awareness of hepatitis B and Delta among people who use drugs, as well as the care providers who serve them in this space. And we also did kind of an assessment of existing multi-level barriers and challenges that exist and that can impede screening, vaccination, and linkage to care for hepatitis B and Delta in this space. And then the second phase was actually conducting screening among 500 community members and working to connect them to care and vaccination as needed. So today we'll be providing an overview of the project, and we hope that this webinar will shed light on some of the barriers and challenges that can impede increasing Hep B and Delta awareness, screening, vaccination, and access to care among people who use drugs, and how these can be overcome, and how health departments can potentially play a role. Next slide, please. Thank you so much. So just to start with some general background, so some of you may already be familiar with this, but in the United States, there's over 6.5 million individuals who have ever injected drugs in their lifetime who report doing so. And of course, people who use drugs are especially vulnerable to bloodborne viruses, including HIV and hepatitis B, C, and Delta. Just a quick introduction for those who may be less familiar with hepatitis Delta, since it's not spoken about very much. It's a satellite virus that requires the hepatitis B virus to survive and replicate. And so it can only impact people who are either already living with hepatitis B or who are at high risk for acquiring both viruses at the same time. And if an individual develops chronic hepatitis Delta, they have a much higher likelihood of developing cirrhosis and liver cancer than individuals who are living with hepatitis B alone. So it impacts, its numbers are kind of all over the place, but it's estimated to impact between 5 and 10% of people who are living with hepatitis B. And it's a serious health concern. It's often cited as the most dangerous of all the different forms of hepatitis because of how quickly it can progress to serious liver damage. So as many of you likely know, HIV and hepatitis C have been well documented in this population, and these infections can often exacerbate hepatitis B and Delta. Prevalence rates of hepatitis B among people who use drugs in the US are also kind of all over the place, but the research that we found is that it ranges somewhere between 4 and 12% for hepatitis B among people who use drugs. Since 2009, coinciding with the rise of the opioid epidemic, acute rates of hepatitis B have been on the rise in this population. Epidemiological data, as I mentioned before, for hepatitis Delta is extremely limited in general, and definitely among the population of folks who use drugs. And so typically low awareness of hepatitis B and D among both at-risk communities and the providers who serve them is quite common. And then just another kind of statistics. So the most recent, or a recent data set from NHANES revealed that about 34% of US adults who were living with chronic hepatitis B were aware of their infection. So only about 1 out of 3, and only just under 12% were aware of a past hepatitis B exposure. So awareness certainly of hepatitis B is very low, and of hepatitis Delta is almost non-existent. So there's a really strong need to increase awareness and accurate knowledge in this population to reduce transmission and incidence. Next slide, please. Thank you so much. So for the objectives that we had for the first phase of this study, they were mainly to just kind of understand some of the barriers and facilitators that might hinder or advance efforts to identify hepatitis B and Delta cases and susceptibility among people who use drugs in order to try to move the needle on addressing some of these really major public health concerns. Despite the existence of guidelines that recommend hepatitis B screening and vaccination in this population, which have now been updated to recommend this for all adults in the United States, but they've always, people who use drugs have always been considered a high-risk population, and so it's always been recommended for these communities. But despite these guidelines, diagnosis and prevention efforts remain really sporadic. So we wanted to kind of document the barriers and facilitators and evaluate existing knowledge and awareness, as well as preferred educational needs and preferences for kind of increasing accurate knowledge in this community and hopefully encouraging health-seeking behaviors. Next slide, please. Thank you. So just a quick overview of the methods for the first phase of this study. So the first thing we did was that we assembled and disseminated an anonymous provider-focused survey, and this was online, and we distributed this among kind of the Hepatitis B Foundation's main networks through the ECHO program, as well as to many providers within a Philadelphia-based health system. And so this portion in particular was meant to document barriers broadly among providers, not necessarily only providers who work with people who use drugs. And then these questions were informed by literature review and key opinion leaders, and we housed it on the platform SurveyMonkey, and all the providers we distributed it to were in the United States. And then in parallel to this, we also conducted 18 key informant interviews, and these were specifically within the community of people who use drugs. So 8 of the interviews were with clients at the HRO, 4 were with non-medical staff, including case managers and drop-in staff, and then 6 were with medical providers who do work with this population. And this was really possible because of a previous connection that we had with this particular HRO. It was already established between the Hepatitis B Foundation and this organization through prior research relationships. So really without that existing foundation, this wouldn't have been possible. So we did these key informant interviews, and the participants who with lived experience who participated in the interviews also completed just a brief demographic survey, just with some very basic questions about age, race and ethnicity, gender identity, sexual orientation, primary language, and drug use behaviors. Again, all interview guides were informed by the literature, and all participants were compensated $10 to participate. Next slide, please. Thank you so much. So this data from this phase was analyzed. Providers who responded to the online survey were categorized into 3 different roles. So they included public health and community workers, clinicians, and researchers. And then we measured 4 different outcome variables. So these included when people indicated specific barriers to hepatitis B and Delta screening, when they mentioned their existing knowledge of hepatitis B and Delta, when they talked about the services that they provided specifically relating to hepatitis B and Delta, and then when we tried to assess different levels of confidence among providers in these different groups in terms of explaining test results and counseling patients on hepatitis B and Delta diagnoses. So that was for the provider survey. Then for the key informant interviews, all interviews were recorded and they were transcribed verbatim. We created a code book to organize the data, and codes were created, again, using a literature review and a subsample of transcripts. And all codes had a specific definition assigned to them. And we used in vivo 14 software to do the analysis. And then we used a double coding process and intercoder reliability to make sure kind of all transcripts were independently coded. And we got a kappa coefficient through that. And then further reviewed and organized the data into thematic categories. And findings from this portion of the study were used to inform the creation of a culturally appropriate and tailored educational campaign that was aimed at increasing knowledge and awareness for both hepatitis B and Delta among community members and providers. So that was a cool outcome that came from this. Next slide, please. Thank you. So in terms of, we'll start with the results of the provider surveys that we did. So just in terms of general demographics, we had 56 providers who participated in total. And you can see the demographics listed out here. All of the survey respondents fit into one of the two categories that we had. So we had public health and community workers, and these included roles like case managers, community outreach workers, peer support workers, et cetera. Or the rest of the participants practiced clinical medicine, and this included people like advanced practice providers, general practitioners, and hepatologists. We only had one participant who identified as a researcher, and they were a medical laboratory worker. We had 45% of participants who had been in their role for fewer than 5 years, and then 20% between 6 and 10 years, and 21% for more than 20 years. And the majority worked in an academic hospital. Next slide, please. Thank you. So in terms of the further results of these provider surveys, so one of the outcome variables that we measured was barriers to screening and vaccination. So you can see this outlined on the table as well. So as many as 67% of respondents indicated that they encountered barriers when performing hepatitis B screening. And the two biggest barriers were not knowing if insurance would cover screening for specific patient populations, and also limited time and competing priorities. Other barriers that were mentioned included the complexity of professional screening guidelines, concerns about patient management or patients' ability to manage their infection once told about their diagnosis, and the difficulty of discussing risk factors with patients was also a commonly cited concern as well. And then barriers to vaccination specifically included patient hesitancy, challenges with completing the full series, confusion, again, about insurance coverage, and the high cost of the vaccine with little demand for it was also mentioned. And then 82% of respondents indicated that they faced barriers with hepatitis Delta screening, so a huge majority. And this included barriers like uncertainty about labs and which labs would actually run the test, again, confusion about insurance, complexity of guidelines, and a lack of knowledge about which tests were needed to fully capture a hepatitis Delta diagnosis. Next slide, please. Thank you. So there were two more outcome variables that we measured from the provider surveys. The first was knowledge tests. So only 7% of participants had a clear understanding of the groups that were most at risk for hepatitis B. But 62% did understand the tests that were needed for hepatitis B diagnosis. So there was more than half had an understanding of the triple panel test that's typically needed. Fewer than half of participants understood that hepatitis Delta co-infection with hepatitis B can cause faster progression to liver disease. And then only 39% of respondents were aware of the tests that were needed for hepatitis Delta, but 60% were aware of the groups that were most at risk for hepatitis Delta and that most needed testing. So it was a little bit the opposite of the hepatitis B findings. In terms of the services provided, 41% of respondents indicated that they screened for hepatitis Delta at all. So that was fairly low. And then in terms of confidence in explaining test results and counseling patients, perhaps unsurprisingly, the confidence of community health workers about both hepatitis B and Delta was significantly lower than that of clinicians. So that wasn't hugely surprising. That was our last kind of finding from the provider survey. Next slide, please. Thank you. So then moving on to the key informant interviews. So we had a lot of kind of valuable quotes from these interviews. So I tried to put those on screen, but just to go over some of the significant themes. So in terms of knowledge and awareness of hepatitis B and Delta among this community, among folks who use drugs. So in general, there was a significant lack of awareness among both program participants and non-medical staff at the HRO. There was a lot of confusion about different types of hepatitis and a lot of conflation of hepatitis B with hepatitis C. Knowledge about symptoms, transmission, and severity of hepatitis B was very varied, and there were different perceptions of risk that were found among different participants. There was in general some level of knowledge that housing instability and injection drug use can be risk factors for hepatitis B. There were some pretty prevalent myths that we encountered. One was that hepatitis B is transmitted similarly to hepatitis A, mainly through fecal or oral contamination and through casual contact or through the air. These were all kind of beliefs that people had. Accurate knowledge of hepatitis C was very high. A lot of people really knew, they knew about hepatitis C treatment and reactivation, and there was a lot of really high levels of knowledge about that. There was also a lack of awareness among providers who work in harm reduction spaces. There was not a lot of knowledge about the prevalence of both hepatitis B and especially about hepatitis delta in communities of people who use drugs, and not a lot of knowledge about the epidemiology of them. People express that screening guidelines, again, can be unclear. And then in terms of stigma around hepatitis B and delta, we got reports that there's just a lot of stigma in the harm reduction space in general, which is, again, unsurprising. A lot of people felt that the knowledge of hepatitis B and delta was too low for there to be specific stigma about them. But some people did still feel stigma about these viruses in particular. And there's a great deal of stigma and shame kind of related to wounds and abscesses that are becoming increasingly common in these communities. And those can impede testing that requires a venous blood draw, such as hepatitis B. We'll get into that a little more later, but that was also expressed as well. Next slide, please. Thank you. So just a few more themes that kind of emerged from the interview. So one was trust in healthcare providers. So there is definitely some mistrust of both medical and non-medical service providers among people who use drugs. The main concerns that were identified were about confidentiality and just people's health information, being spread to the wider community, and feelings of not being listened to or taken seriously. And then in terms of prevention of hepatitis B, again, lots of barriers mentioned around vaccine access and hesitancy. There was confusion about the number of doses needed and the schedule for the completion of the vaccine series. One reason that was particularly interesting that was cited for hesitancy around getting the vaccine is the need for bodily autonomy. So people, especially as the drug supply becomes more and more contaminated, people feel they have less and less control over what goes into their bodies. So not getting the vaccine is actually a way to control what goes into your body. So that was a particularly interesting point. And then just weariness from COVID, which, is, I don't think, unique to this population. The cost of the vaccine was, again, an issue. And then just vaccination and healthcare in general are often not a priority for this community that is typically living in survival mode and trying to meet, very basic needs of housing and food, et cetera. And then lost to follow-up, again, because of the need for multiple doses. Next slide, please. Okay, thank you. So then just the last couple of themes. So in terms of the current landscape of screening practices and barriers to screening and linkage to care for hepatitis B and delta. So again, for hepatitis delta, it's for quite a long time, the only lab that offered the tests for hepatitis delta was Quest Diagnostics. This seems to be changing, and now LabCorp is hopefully offering the tests starting this year. But not having them available at LabCorp excluded about 50% of the lab market in the United States. So that wasn't great, that lack of availability. Additionally, that there are two tests that are really needed for hepatitis delta. Only the antibody test is readily available, which tells you if someone has ever been exposed to hepatitis delta, but the RNA confirmatory test is very expensive and much more difficult to access. So that was also mentioned. Referring community members to external specialists. So if someone does test positive, getting them connected to a hepatologist or even to primary care or a provider outside of the HRO is very challenging in terms of, transportation cost, a lot of other kind of barriers that this population tends to face. Again, phlebotomy and the need for venipuncture is an issue as well with for this population, as well as long wait times for appointments and concerns about withdrawal. provider time and capacity are limited. And there were a lot of providers mentioned overwork and strict requirements, particularly for street medicine teams that oftentimes have funding to fulfill very specific objectives. And if anything kind of falls out of those objectives, they don't really have the bandwidth or funding or capacity for. And then finally, in terms of recommendations for education, there was a lot of enthusiasm for a targeted culturally competent campaign. And some of the main messages to include that community members mentioned are that hepatitis can affect anybody, clear information about transmission, risk factors, viable testing practices and behaviors that are and are not able to prevent transmission of hepatitis B and Delta, and also clearly outlining the different types of hepatitis. Balancing information about risk factors in a non-stigmatizing way is really important. And then the resources themselves could include things like flyers, brochures, fact sheets, and posters. And a lot of people mentioned trying to fold information into existing information about safe injection practices. And then in terms of educating non-medical staff members, both physical and digital materials were cited as helpful, as well as small presentations. Next slide, please. Thank you. So this will be my last slide, and then I'll hand it to Holly. So this is just some of the main discussion and takeaways that we had from phase 1. So basically, there's a significant lack of awareness about hepatitis B and Delta in this space, a lot of stigma in the harm reduction space in general, and major barriers that impede access to services. And there's definitely a need for tailored and thoughtful education and awareness efforts. Provider training, especially at the primary care and community health level, is really important. Accessing vaccines is very challenging and expensive. One kind of possible solution to this is a sort of one-stop shop model where the first dose of the vaccine is administered simultaneously with screening. And this is something where health departments could really play a role, and Holly will talk more about that in a little bit. And the vaccine would have to be, people would have to be screened first and then get the vaccine to avoid false positives. A centralized screening location with really good options for linkage to care and flexibility for this population would be really helpful, and would avoid kind of the long wait times and the rigid requirements that often accompany specialist appointments that I mentioned earlier. And informational messaging that is centered around the lived experience of drug use and disease can really allow people who use drugs to feel supported while learning about possible health risks. And then this can be a really good opportunity to fold in targeted screening and education and linkage to care for hepatitis B and Delta with hepatitis C and HIV programming, which is already quite robust in a lot of harm reduction spaces. And so we can do things like mentioning hepatitis B in all educational materials that already exist around HIV and Hep C, including that hepatitis B is needed for anyone or hepatitis B testing is needed for anyone to start DAAs or PrEP, and also emphasizing the message around U equals U. So undetectable equals untransmissible can be a really powerful message as well. And then there's a number of kind of broader policy recommendations, which I won't go into here for the sake of time, but these include political and financial support, reflex testing, point of care testing, and just more supportive and comprehensive services for people who use drugs in general. Okay, so I will wrap up here and pass it over to Holly. Thank you so much.
All right, next slide, please. Perfect. So I'm going to move on to the second phase of the study, where we work directly within a Philadelphia harm reduction organization to test 500 individuals for hepatitis B and D. Existing research shows evidence of inconsistent testing within this population, and in general for hepatitis B, as Beatrice mentioned, and sporadic estimations of HBV and HDV prevalence. So our goals with this portion of the study was to raise awareness about HBV and HDV and accurately assess the prevalence of the two viruses in this population. Additionally, we help facilitate connection to vaccination and management as appropriate, and ultimately wanted to use this as a pilot program for outreach, education, and screening within the harm reduction setting in the US, and hope that it would provide a model for integration of HBV and HDV screening in this population. So if you can go to the next slide for me. Thank you so much. So in terms of how we actually recruited 500 people to do this, as Beatrice mentioned, we had an existing connection with this harm reduction organization in Philly from our institution of Hep B Foundation, and they were an incredible team that helped us with recruitment at the site daily, where they took about 20 to 30 names a day for people to participate and controlled a little bit of, getting people over to us to complete the rest of the steps that we were on site to provide. So again, that connection to existing organizations is vitally important and to maintain those relationships. We introduced a little bit of education about hepatitis B and D through the consenting and demographic survey process. And we asked general demographics as well as high-risk behaviors such as history of incarceration, the previous hepatitis infections, injection drug use, and experience with transactional sex. Then they met with our wonderful phlebotomist, who did a 3 milliliter venous blood draw to be sent to Quest for hepatitis B triple panel testing, which included the hepatitis B surface antigen, which indicates positive for current infection, hepatitis B surface antibody, which indicates protection either from past infection or vaccination, and Hep B core antibody, which usually indicates previous infection, when also seen with surface antibodies. So I'm sure y'all are probably aware, but just to cover our bases. And for those who tested positive for surface antigen or isolated core antibody, we kind of treated those without the presence of surface antibody, treated them as a possibility for current infection. They were sent for a total antibody test for hepatitis delta in order to identify whether or not hepatitis delta was present as well. So finally, we encourage participants to come back in a week to receive their results and discuss them with a staff member from Hepatitis B Foundation so that we could educate and link to care if needed. And upon completion of the blood test, participants were given $20 cash incentive to decrease loss of follow-up. They were also given $15 cash incentive to come and do that discussion with a staff member and receive their results. We'll get into more of the pros and cons of that incentive process, but at least wanted to mention it here as a part of that methodology. And if you can go to the next slide, please. Perfect. So in terms of data analysis, this is still, we're working through it and hopefully going to publish here in a little bit, but we'll at least give y'all a little bit of the rundown of how this went and the preliminary results. So demographic information was extracted from platform. We used Open Data Kit, if anybody's curious, and testing results were compiled from Excel format and all data was cleaned. We obtained odds ratios from the behavioral factors to different HBV results. And then additionally, a logistic regression identified any possible predictors for infection, either surface antigen positive or isolated core antibody positive. So if you can go to the next slide for me. Thank you. We'll go into the basics of our screening results. So far here are basics results for screening. We screened 513 individuals, but only 498 were used in analysis due to missing data points. Of those 513, 10 tested positive for Hep B surface antigen, which means they have current infection. 11 also tested positive for isolated Hep B core antibodies, which means they do not have developed surface antibodies and will need further testing to identify whether or not they have current infection or in the process of developing antibodies from a recent infection. We found one positive for Hep Delta antibody result, and in this case, the participant was linked to care for additional testing to confirm the presence of Hep Delta RNA. About 70% of our participants were protected, meaning they showed presence of Hep B surface antibody. 18% of all participants had a previous infection, and 53% of participants had been fully vaccinated. A quarter of the participants didn't show presence of any Hep B antibodies, but 10 individuals were able to complete their first vaccine dose with the Philadelphia Department of Health immunizations team that comes on site to this harm reduction organization the first Tuesday of every month. So we definitely took away that was an important part of this process. And finally, we saw 89% of participants return to receive their results and discuss next steps with staff members. So we thought that was a pretty incredible thing to be able to achieve and at least get another opportunity to discuss results instead of just a large loss to follow-up, which is common for this population, as noted in our first phase. If you can go to the next slide for me. Perfect. So from these results and data analysis, these findings show that compared to a similar study conducted in 2018 in Philadelphia PWUD populations with the prevalence of Hep B and Hep D, it has actually remained consistent over 5 years, but there was no notable evidence that vaccine protection has definitely increased and virus susceptibility has therefore decreased. This shows positive trends in vaccine uptake for PWUD population in the last 5 years. And then our statistical analysis shows that previous incarceration has indicated, as indicated in the demographic survey self-reported, is the most correlative factor to a current infection or the antigen positive. And additionally, current experience being unhoused or previous experience engaging in transactional sex has indicated in the demographic survey is most correlative to a core antibody positive result. And then if we can go to the next slide. Sorry, I know I'm rushing through a lot of information here, but I want to make sure we get through the bulk of it so that we can address any questions and further conversation on how this can apply to your specific jurisdictions. So in terms of lessons learned, the pilot program was fairly successful, and we learned some really valuable lessons for other programs that wish to implement this model in their own organization. So first off, like Beatrice said, the study would not have been possible without an incredibly skilled phlebotomist. So with this population, a lot of times they have really difficulty with venipuncture, whether it's really like hard veins or just a lot of damage to the veins themselves. And so we had a really awesome phlebotomist that helped out with that. And that made it run smoother for us, and then also for the participants. You know, they really appreciated that part of it. And then alternatively, once a point of care blood test for hepatitis B is approved in the US, that would not require an official phlebotomist to conduct the testing, which would provide quick results, reduce loss to follow-up for participants in the week that it took for us to get those results back. So, I mean, obviously a great phlebotomist is the best way to go as of now, but we really need that point of care test, especially when dealing with this population. And another key part of making this study successful was the use of incentives. So in the harm reduction space, incentives are commonly used to encourage preventative health behaviors such as various health screenings, and contributed to how quickly we were able to recruit participants in our high return rate for the results discussions. And although we use cash, there are other options for convenient you could use a convenience store gift card, like a Wawa gift cards we would seen around the organization they'd used, and other services that are offered at the organization, like a credit, things like that. And although this helped initially, there were some drawbacks that I will mention to using cash specifically due to participant desperation. We saw participants trying to get screened multiple times under fake names and birth dates, returning for results multiple times, even though they had previously had the discussion, and even trying to forcibly take incentives from the team. But ultimately, with the goal of screening and making the participants aware of their status, the incentives were pretty key in the success of this part of the mission. And finally, there were some difficulties with linking positive infection participants to appropriate care in the same harm reduction setting, since there are so many restrictions on who can actually be seen by the on-site medical staff. So for example, we were told that only ones who had a positive HIV infection could be seen by the on-site physician. Then that changed to include those with a positive HCV infection. But for those with neither, there was no on-site provider that could see them technically. And so we had to link them to other local providers to try to support them with transportation and follow-up. But of course, this led to additional opportunities for like loss of contact during the time between appointments, et cetera, et cetera. So that was another difficulty just in terms of what we were trying to provide with the management of positive cases. And if you can go to the next slide, please. I think this is my last one. So overall, our main recommendations after completing the study was that there's significant need for approval of a point of care testing, as I mentioned, in the US, and specifically for use in the harm reduction space and PWUD population. And this program showed the efficacy of offering multiple services at one trusted organization site, and shows the need to expand the capacity for harm reduction organizations and syringe service programs to reach this population and support preventative health practices. So again, getting into the highlighting of connecting the local health departments and jurisdictions to these existing organizations that this population is comfortable with and trust and go to frequently is vital. And so, like I said, we had that model where the Philadelphia Department of Health would come at a regularly agreed upon time. And obviously we had one time where they didn't show up that month, but that, you know, can come and go as needed. But that contract or agreement that would be a service that is provided ongoing is a place that really improved some of the care for this population related to Hep B. And so this may be an appropriate model for replication in other areas that will reduce the burden of the organization staff directly for harm reduction organizations and still allow for accessible services to the population within their own trusted community. So I think that is pretty much all I have. We can go to the next slide. I think it's just a thank you and questions. And we'll stop it there. Thank y'all so much for coming today.
Yes, thank y'all so much for the presentation. It was a lot of really great information and y'all were able to distill it really well. And I think there's a lot of applications, even though this was research, that health departments can use in their programming going forward for hepatitis B and Delta. I'm gonna see if we have any questions from the group. We have a couple of questions and some discussion about purchasing of vaccines, using state funds, using federal funds and other funds. I don't know if anyone wanted to discuss a little bit about how y'all were able to, I guess for Beatrice and Holly, how you all partnered with the health department to provide some of those. And we do have folks from Philadelphia on the line. I don't know, Danica, if you
Yeah,
want.
probably Danica, you could. This was an existing, you guys have been going to Prevention Point already for a long time, before we ever came. So I don't know if Danica wants to share.
Yeah, hi guys, and this was really amazing. I'm really excited to see these findings. Yeah, so we've worked closely with this organization for a long time. The 2018 study that was referenced was a project of ours, and so we've had established relationships there. Vaccine is always a challenge. You know, the 317 funds for us are everybody's hands are tied, and those ceilings are so low for all the vaccines that are needed. So we've been able to petition or ask for some additional local funds to come to our program, and been able to allocate some of those every year for the past few years to purchase some doses for Hep B. And then, and I said in the chat, we use Heplisav B. And we also, so we've partnered with this harm reduction program and done street outreach as well in the community to help vaccinate folks who just are not getting into providers who offer vaccine or don't feel comfortable or welcome in a pharmacy setting. So it's not a blanket solution, but it's been a safety net for some folks, especially in this organization. So we were very excited to have this study be a feeder, you know, to communicate with people to get vaccinated. So thank you guys. This was awesome.
Yeah,
And I'll just mention something else. Outside of the providing vaccines for uninsured individuals, the harm reduction organization also, anytime that we identified someone who needs some form of linkage to care, the first question was, how do we try to get them some form of already available insurance for people who are in the harm reduction need and space, unhoused, etc. So that's a possibility, trying to get them on some basic form of insurance. And there are a few. I actually just had a presentation from Giant with an immunization coalition. They will actually come out to different clinics and provide like adult vaccines as long as they're insured and just bill the insurance. So outside of that, there are some other creative solutions, I think, even if funding isn't available. But yeah, related to how the city department was able to fund it. Thank you, Danica, for coming and putting in that information.
Yeah, and one thing I wanted to add just for everyone, we did not match our IIS data to these to the data from this study, and so there may be additional people who are vaccinated who are empowered by their test results who were vaccinated outside of this setting or once they were linked to a provider. So just putting that out there, that it might be broader coverage than what you guys were able to find.
Yeah, that's definitely true for sure.
Yeah, I don't know, anyone else on the line, had some thoughts or had some creative ideas for funding, adult vaccination for, uninsured populations? All right, I did see we had a question, what funding was used for incentives?
This was funded by a grant from Gilead Sciences.
Okay. And I guess I have a question for the group at large. Like, how are you all funding, or is anyone using incentives to increase folks receiving testing or vaccination or any services like within harm reduction or any other community-based thoughts? Hmm. And it's good to know in the chat that the state opioid response funds can be used to fund vaccine for folks that use drugs. And also partnerships with Walmart pharmacies and grocery store pharmacies to increase access outside of clinical settings. Okay. Anyone else had any thoughts about incentives or being able to provide those for folks seeking testing services? Right. Okay, I want to open it up to the I hear from Esther, they have restrictions on what the state can do regarding incentives, so community partnerships are invaluable. Definitely.
Yeah, and even I'll just kind of mention the alternatives, like I mentioned, you can do cash and things like that, like we were able to do, but the popular one that was already in existence at this organization was a credit for existing services. So a reason that people come to this organization is to like to get food or use the syringe service program. So like I think at one point in terms of incentives for vaccination, because that's so commonly used, they had said you'll get a credit on the syringe service program and things like that. So that can sometimes be controversial as well. Incentives commonly are controversial, but there's other ways to model incentives other than cash, because we know that's very hard to access in the nonprofit and harm reduction space in general. So yeah, definitely just the conversations with harm reduction organizations locally, I think can highlight a lot of ways to format incentives differently and still be a benefit for the participants.
Yeah, thank you so much, Holly. Okay, we have a question. What was the average age of those tested? I'm glad to see about half were vaccinated. Do you have a sense if more of this happened during childhood or adulthood?
So the average age was around 40. So many people who were, born like in the early 80s. But the age range, I think it was like from 18 to early 70s. But yeah, that was the early 80s. Birth time was definitely the most common. So there were some people who would have been born after the childhood recommendations were implemented, but a lot of folks weren't. Yeah.
Yeah. Do you know when y'all started requiring hepatitis B for school vaccines in Pennsylvania?
Oh, I don't know. I don't know for Pennsylvania specifically. I think it was 1991.
Early 90s.
Yeah, that it was for the US, but it might be different by state. I'm not 100% sure.
Some. All right. Any other questions from the group? Well, I don't know. A lot of the, oh, sorry, I'm reading the chat. We hear from Rachel, some programs have had prizes in addition to incentives for completing multiple milestones. Clients can request what prize they like from a selection of options or make a specific request for something in advance. So options. There's a lot of misconceptions that people born within the mandatory school vaccine area, that is assumed that they are vaccinated and have immunogenicity, and they simply do not. Yes, that is an issue as well. It's something to consider, especially when looking at the age of folks and making sure that they've been vaccinated. Well, I think the two-prong approach that you all took to address, like in seeing what the level of knowledge is and around hepatitis B and Delta with providers and with patients and in harm reduction setting, I think it has a lot of overlap with some of the work that health departments are doing currently, especially on assessing healthcare providers on whether they have been able to implement the recent the recent universal screening recommendations. So I was wondering if there's any specific lessons learned about that process with like working with providers, working with patients to gain trust with them, to get good response rates and things like that, that help you all get such rich data that I think a lot of jurisdictions may be having a little bit of issues with. And also how y'all been able to use the data that you gained from providers to inform your educational materials.
Yeah, well, I can start. Holly, feel free to jump in. I think, so in terms of, so kind of having the existing network that like, especially through the ECHO program, that is kind of the monthly program that provides hepatitis B education to providers, that really helped to get respondents to share feedback with us. And also we had, kind of really had a strong collaboration with a existing health system in Philadelphia. So that helped a lot with distribution of the survey. And then in terms of engaging providers actually within the HRO that we worked with was actually pretty challenging because people are only on site for certain days of the week. And when they're there, you know, they're obviously busy seeing folks and caring for them. So that was pretty challenging. So we had to do creative outreach to different folks who work in different capacities and harm reduction throughout the city. So yeah, so it's just kind of like building on existing relationships and you know, making sure that people know that their input is valuable, and also not framing it so it's not like a test of any kind, you know. So like if people are perhaps lacking in knowledge about hepatitis B or Delta, you know, it's just a learning opportunity. It's not that they're not being tested, I think. And then in terms of how we're using the provider data, I think we actually still need to kind of think through that. We've created sort of educational materials for non-medical staff and for community members, but in terms of sort of raising awareness for providers, that's something we still I think are considering kind of how best to do. And we have been, one idea was specifically for HROs was to kind of design like a guide, sort of a step-by-step guide for how to conduct this kind of screening and vaccination based on different levels of infrastructure and support that exist within HROs. So for some, it might only be education. That's all that they have the capacity for. But for others who perhaps have stronger networks and infrastructure, you know, how to kind of implement this into the services that they're already offering. So yeah, so that's kind of some of the takeaways we have initially.
Yeah, I like that about having like different methods of entry into increasing like activities around hepatitis B and Delta. So if there's only capacity for education for that, but then also building on that So hopefully when there's increased capacity, they have a tool and framework to build on that as well. Thank you. I did see a question from Alan. It says some jurisdictions have good Hep B programs already in place. Some are just starting out. For jurisdictions that are just starting, what are the first few things that you encourage them to work on? Offering vaccine at health department, collecting more surveillance data, linkage to treatment, etc. And we have a good response here from Anne. Thank you so much, Anne, but I don't know if anyone else wanted to add on or provide some guidance for Alan and other jurisdictions that are looking to increase their Hep B activities.
My first thought is the surveillance of what's already available and what's needed from different perspectives. So from the providers, from the public, from any populations that you're really wanting to gear this program towards is obviously the first step in figuring out what gaps it's necessary for you to fill with Hep B care. That's the first thing that comes to mind. I would say, I mean, vaccines can be really expensive. Testing can also be kind of expensive, but I mean, I think screening is my initial thought, is like starting out and just kind of getting that baseline data and really figuring out, you know, if you do need to focus more on, are there positives? Do we need to link to care? Is it as everybody's already vaccinated and things like that? That's my first initial thought, but that can absolutely be wrong.
No, I would definitely agree with that. And I think too, just really, you know, the level of HIV, as we kind of referenced before, but the level of HIV and hepatitis C infrastructure that already exists in the harm reduction space is pretty strong, at least, I mean, just speaking for Philadelphia, but, you know, so I can't speak to other places, but from what we saw, you know, everyone knew about HIV and Hep C, you know, had really strong existing knowledge. People were coming regularly for HIV testing and PrEP, and for Hep C testing, you know, people were well connected. There's existing streams of funding for providing HIV and Hep C care for providers, and for HROs that have medical staff on site. So really trying to integrate, I think, you know, rather than, you know, because reinventing the wheel is exhausting. So avoiding that by really trying to integrate into these existing infrastructure, I think is really important, especially because, you know, like treatment for Hep B is quite similar to treatment for HIV, you know, and they're not, in terms of the diseases themselves, they're quite similar. So so trying to find ways to kind of move into those existing infrastructures, I think is important, especially also because Hep B testing is needed for, you know, if it's needed to commence Hep C treatment anyway. So.
Very true. And I also will just piggyback onto that with what I was thinking with data and utilizing, and what Beatrice said with utilizing existing networks. A lot of times there are these smaller Hep B focused groups, working groups, HIV, Hep C, things like that, and finding those partners rather than having everything be a department level or state department level effort. It can definitely release some of your burden and also make them feel connected to your mission and things like that. I think as an organization, we see that a lot. It's like every individual institution that we try to get in contact with has their own thing, and we're doing a lot of duplication. And so trying to find ways to collaborate and connect existing services and people who are passionate about that can really just be helpful. And they may have more insights based on what they already know about where you are and what the status is too. So I'll just say that.
Yeah, definitely. Collaboration is the name of the game. And I think also, like, just for general folks' awareness, like, folks know what HIV and Hep C is. So they pretty much know, like, a lot of the mechanisms for Hep B and for Delta. So just bridging that together and letting folks know, hey, this is vaccine preventable. You might have already been vaccinated for this. So just trying to increase awareness and connecting it to what folks already know about, like HIV, Hep C, I think is another way of increasing awareness of Hep B in, like, the general population. Yeah. Yeah, the hepatitis ship isn't coming. So we have to make sure that we integrate ourselves in existing infrastructure. I like that. Have any other questions from folks? I did have a question. I guess in talking about like building awareness and some of the things that Beatrice that you mentioned, like what are some ways that through our education, through our outreach efforts that we can like increase awareness and also reduce some of the stigma and some of the vaccine hesitancy that folks have in regards to hepatitis B and Delta. So that way folks feel more comfortable in seeking screening, treatment, or vaccination services, especially like in a harm reduction setting.
Yeah, I think that's a really big question. I think, yeah, it's really challenging because the stigma is so pervasive. The stigma just around, you know, drug use in general is so entrenched. So I think it's important to so yeah, so the conversations around HIV and Hep C have actually become quite normalized. And I think, you know, people are still, just from the folks that we talk to, it's still, it's obviously, you know, it's a burden to receive this diagnosis, but people are just kind of adopted into sort of everyday life that they, you know, if they're able to, they need to follow up and complete this course of treatment and then continue to get to make sure it doesn't become reactivated, you know, et cetera. So I think just trying to have that same, trying to just normalize the discussion around hepatitis B, trying to emphasize that, you know, we always try to really underscore that, you know, it's not a death sentence. It's not, you know, it's a manageable condition. You can live, you know, a long and healthy life, and trying to just sort of drive home that message. And I think, you know, the fact that we had sort of an immediate action step that people could take too is really helpful. So like being able to provide the education and be like, okay, like now you can get the test and then, you know, tomorrow or in a couple of days come back and get the results. So having that kind of complete cascade of care was really helpful as well. And really emphasizing, you know, that anybody not kind of going on about how it affects people who use drugs. Like anybody can get hepatitis B, you know, and it's the most common liver infection in the world. And a lot of the points that we use to really kind of educate, you know, even people who are from countries with high HBV endemicity or other populations that are heavily impacted, I think those same messages are very applicable, you know, to this community, and that we're not trying to add like yet another burden, because also to be cognizant that people are so, you know, they're constantly being told that their lifestyle is dangerous and that they're, you know, it's like message after message that it you know, devalues their humanity and lowers their dignity in a way that they encounter every day. So try not to add to that burden, but just integrating this into healthcare and, you know, a holistic approach to well-being for these folks. So yeah.
And I know we just hit the 4-minute or the 4 o'clock mark, but I'll just throw in my last 2 thoughts on what we saw and what I saw personally being a part of this project is the people who participated wanted to take the best care of themselves in general that they could, aside from what they're currently going through, whether you use drugs or has things like that. And so highlighting that this is a way for them to keep on top of their health and try to do what they can for themselves, and that these are services available, and highlighting that there's people who want to help with that. And so I think that was just a positive that I wanted to tell everybody that we told this presentation to is there are a lot of people out there that want to know their status and want to stay as healthy as possible. And so coming in with that mindset and wanting to help rather than shame. And they may just be like just being conscious of that framing and things like that. So that's my 2 cents there.
Yeah, no, that's definitely good framing. And do I have like 2 seconds? We have a question about mpox. Okay, so I want to thank you all for folks that may be leaving. Thank you all so much for everything. And I'm gonna get to Esther's question and then I'll do like a full thing. I did say Esther had a question. Any ongoing collaborations for sharing resources or joining forces when providing mpox vaccines?
I was
Not
going to say
to
the
my
only
knowledge, but yeah,
yeah, I don't think
but
we
that's a
did.
great idea.
The Philadelphia Health Department, when we were there and they had the Hep B vaccine, they also had monkeypox. And so it may be more of a health department specific. We didn't have a lot that was going on with it. But I think with the services that provide vaccines, they definitely had still an ongoing collaboration of trying to get that vaccine uptake going. But yeah, related to what we were doing, not as much and not to my knowledge.
Okay.
And they had COVID and flu, like, and Hep A as well. So really like it ran the gamut. But I think definitely combining forces wherever possible is awesome.
Okay. Yeah, thank y'all so much. And also, if folks have any thoughts of combining, having a general health and wellness, especially including mpox and other things, feel free to let us know and let Esther know. But I want to thank so much for our presenters today. I don't know, this is a really great topic. Y'all have done really great work, and we're really appreciative of you sharing this with us. And I don't know, thank y'all so much. And thank you for everyone else for your comments in the chat. Thank y'all so much for sharing everything that y'all are doing. It's a really great space. So thank you all, and thanks for staying like an extra 3 minutes. Y'all have a